Hello everyone, I'm Professor Dong-Seok Sohn at Department of Oral and Maxillofacial Surgery, Catholic University Medical Center of Daegu. I'm very honored to be invited to first international symposium of complication in implant dentistry. Unfortunately, I'm very sorry I cannot meet you personally in this symposium due to COVID-19 crisis. I hope all of you to be safe and to overcome COVID crisis well. Before I start my presentation, I'd like to express my sincere appreciation to Dr. Mohadas, who is Congress Chair. I remember he did a wonderful lecture in last World Cup's meeting held in Netherlands. Thank you very much for inviting me to Iran. And my thanks go to Dr. Ali, Mr. Amin, who is president of Dr. Tahis, and Mr. Lee, who is president of Biotem Implant, for inviting me to this symposium. Exactly 10 years ago, I was invited to International Implant Symposium held in Tehran. After my lecture and my hands-on course on pr surgery, I was very happy to meet my old friends and new Iranian friends. This slide shows you the Persepolis, which is known as the first United Nations, established about 205 years ago. I was very honored to be able to these brilliant ruins of the great Persian Empire after my presentation in Iran. What I'd like to talk about today is a simplified three-dimensional ridge augmentation using StickyBone and tenting abutments. Atrophic alveolar bone with a large defect is a challenging site to restore with implant-supported restoration due to aesthetic and functional demands. For predictable bone regeneration on the defect, 4 biology principles, which are primary occlusion, angiogenesis, and space maintenance, and the stability of wound and implants, are necessary according to the Homney's publications. Among them, the most critical factor for successful 3D ridge augmentation is space maintenance. How can we maintain volume or bone graft during healing period? This slide shows my old method to maintain grafting materials for 3D ridge augmentation. This is chin bone graft. This is titanium reinforced Gore-Tex method. This is titanium mesh assisted 3D ridge augmentation. Black bone, autogenous black bone is known to the only osteogenic, osteoinductive, osteoconductive materials. So this black bone can provide solid space maintenance for 3D ridge augmentation. I used to be a big fan of ortho black bone for 3D ridge augmentation, as shown in this my published publication in 2007. This patient came to me with a complaint of severe tooth mobility of her left anterior bridge. So this teeth was extracted and 2 months of teeth healing was allowed. And full thickness flap was elevated to expose bony defect. Take a closer look at the huge 3D defect. pr surgery was used to harvest a thick, 6 mm thick chin bone, and this block was divided into the 2 pieces. Each block bone was fixed with the 2-point fixation with micro screws. Orthobone chip harvested from chin was grafted on the residual defect. Two mini implants was placed at the same time in order to deliver immediate temporary restoration. This is post-op. This is 1 month healing. Healing was uneventful, but patient complains the mild numbness and moderate facial swelling after surgery. 4 months healing was allowed, and the implant was placed, and immediate restoration was delivered on the next day. This is final restorations. This is before. This is after delivery of final restorations. This is 15 years in functions. This is the periapical radiogram of baseline, and this is 17 years in functions. You can see good marginal bone stability. However, there are many disadvantages of autogenous black bone grafting, as shown on this slide. So, secondary donor site is required. The bone resorption is sometimes unpredictable. The wound exposed can cause serious complications. This technique is a very difficult task, and we cannot place the implant at the same time, so the dangerous healing period is delayed. This slide shows one of the complications after harvesting of a chin bone. You can see that the facial swelling and the ecchymosis. It takes almost 1 month until all ecchymosis is completely removed. This is my colleague's case. He did the harvesting of ramus bone with the high-speed burr, but he cut the artery during osteotomy. So this severe bleeding happened and reported to me to control these severe complications. So I found out the damaged artery, and the artery was tied to control bleeding, and gelatin sponge was packed to control the bony bleeding. This is 1 day after. He was admitted for 2 days to compensate the blood loss. So I recommend to use piezo surgery when you osteotomy intraorally to protect the soft tissue or vital organs. This slide shows one of the disadvantages of autogenous black bone. As shown on this slide, according to some studies, intraoral black bone revealed about 17% of resorption after only 4 to 6 months of bone grafting. Iliac crest shows you about 50% of bone resorption over time. This is my case is using ramus black bone. The piezo surgery was used to harvest ramus monocortical black bone, and for vertical augmentation, the black bone was grafted on the recipient side, and sinus bone graft was done at the same time. Collagen barrier was carved over the bone graft. After implant was placed at her dentist. After 5 years in function, she came back to me for a follow-up. You can see that the complete loss of the ramus bone. After 13 years loading, she came back to me for further evaluation. No more bone resorption is seen, but the cortical bone is completely disappeared. This is another complication of the black bone, which is a graft failure, graft infection. The chin bone was harvested and grafted on the anterior maxilla for horizontal ridge augmentation. After 5 weeks healing, infection happened. I was very shocked to see these complications. So saline irrigation was done to control the infection. It was effective. After 6 months healing, 3 implant was placed, but black bone on the site of a previous infection was not integrated. And you can see the fractured segment here. So secondary GBR was done. Final restoration was delivered by my colleague. After 2 years loading, you can see the marginal bones here. So I'm not happy with this result. This is my colleague's case. He did GBR with a simultaneous implant placement at the anterior aesthetic zone, but his first surgery, augmentation surgery, was failed and referred to me to control this complication. So these 2 implants were removed and soft tissue healing was allowed for 8 weeks. This is the preoperative cone-beam CT showing huge vertical and horizontal defect. After 2 months healing, full thickness plate was elevated to expose the recipient side. Take a closer look at the huge defect, vertical defect, about 6 millimeter vertical defect. So chin bone was harvested for 3-dimensional ridge augmentation. And 2-point fixation was done, and particulate autogenous bone chip was grafted on the residual defect, and the bone graft, particulate bone graft, was stabilized with the commercial fibrin adhesive. And very good tension-free releasing incision was achieved. However, 6 weeks later, the black bone was exposed. I was very embarrassed to see that these problems. So the flap was elevated, and you can see the pus on the recipient side. So the black bone was removed, and wound was cleaned with antibiotic solutions, and 2 tenting pole screw was placed at the same time on the same day to support a particulate bone graft to prevent collapse of a particulate bone graft during healing period. An antibiotic tetracycline soaked allograft was grafted for 3-dimensional ridge augmentation, and a collagen barrier membrane was placed with no membrane stabilization. The primary wound close was done. Releasing incision was made on periosteum and the buccal tissue, and the pregingival graft was done at the same time. To stabilize the pregingival graft, tetracycline, which is medical grade super glue, and suture was utilized. After 4 months healing, excellent 3-dimensional ridge augmentation was gained. Why did I use the black bone graft in this case if I can get this beautiful result with the particulate graft material and tenting for screws? This is the final restoration was done by my colleague. This is 3 years in function. This is 5 years in functions. You can see the little bit marginal bone knobs here. This is 11 years in function. The marginal bone is very stable now. Surgeons would like to treat challenging cases with complicated surgery, but patients don't want invasive surgery. So implant-related augmented surgery should be done as simple as possible to minimize patient post-operative discomfort. As an alternative to black bone, so I moved to the titanium mesh to support solid space maintenance. Take a closer look at the huge vertical defect here. So maybe more than 10 millimeter, about 15 millimeter high vertical augmentation was needed on the right posterior mandible. So the intraoral black bone is not suitable for these augmentations, or you need to use the iliac bone crust or other techniques. But as I mentioned before, iliac bone graft showed about 50% of resorption over time. So I choose the titanium mesh in this on the right side, and on the left side, I used the sandwich osteotomy with the interpositional bone graft for vertical augmentation. So the 15 millimeter high vertical augmentation was done with the titanium mesh and the pre-conditioned allogenic materials on the right side, and on the left side, the alveolus bone was segmented like this with piezo surgery and moved coronally about 9 millimeter high and to get vertical augmentations. This is a post-op radiograms. The implant were placed after 6 months healing. Long implant was placed on the right side, on the left side. This slide shows radiogram after 12 years in functions. A little bit marginal bone desorption is seen on the right side, but it seems to be very stable. There is no bone loss on the left side because I used the pedicle bone graft using sandwich augmentation. This is not pre-bone graft. However, there are some disadvantages of titanium mesh technique, as shown on this slide. This technique is technique sensitive. So, titanium mesh technique shows high risk of early exposure of membrane. Titanium mesh. When once mesh is exposed at early stage, the bone graft will be failed. So titanium mesh is difficult to remove it after healing. So you need to consider there is always 1 or 2 millimeter thick connective tissue under mesh. So you need to consider soft tissue when you place the dental implant after removing titanium mesh. So you need a more deep placement of dental implant. I have many good cases using titanium mesh, but I like to share my failed, complicated case using titanium mesh. This lady came to me and he asked me, is it possible to deliver immediate temporary restoration after implant placement? Wow, this is a very challenging case. I promised her, yes, you can get immediate restorations after extraction and after implant placement. So after extraction, this is a preoperative panoramic view. You can see the huge vertical defect on the posterior mandibles. After extraction, the immediate temporary denture was delivered. After soft tissue healing, implant augmentation surgery and implant placement was done. This is a preoperative cone beam CT showing huge 3-dimensional defect implant on the both posterior mandible and maxilla. This is a preoperative view after soft tissue healing. So the implant was placed at anterior between mental foramen, and some 2 or 3 mini implant was placed at the same time to deliver fixed immediate restoration after surgery. And titanium mesh was used to get good space maintenance after bone grafting. This is the immediate fixed restoration using 1, 2, 3 mini implant and 2 dental implant. After 4 months of healing, you can see the expose of titanium mesh. This is the late expose of titanium mesh, but the augmented area was infected, so all grafting material was disappeared. Take a closer look at the most posterior area on the left side. You can see the complete loss of bone graft. I could not titanium mesh again in this area, so I did a simple GBR using sticky conditioned bone graft and collagen barrier membrane was carved without bone tech or without the membrane stabilization suture. This is the right side. The healing was uneventful, but so bone healing was good. But take a closer look at the soft tissue formation under the titanium mesh. So when you place the implant, you need to place the implant deeper to the this soft tissue. So 2 implants was placed. After 6 months healing on left side, you can see the good 3-dimensional ridge augmentation without titanium mesh. It's an amazing result. So 2 implant was placed. This is the final restorations. This is 7 years in functions. Even though I used particular sticky conditioned bone graft with the collagen membrane for 3-dimensional ridge augmentation, but space maintenance was very, very excellent. There is no reason to use the black bone or titanium mesh for 3-dimensional ridge augmentation if you have the sticky conditioned, immobilized particulate bone graft in your hand. As shown in this case, simple GBR using peribone plays an important role for 3-dimensional ridge augmentation as an alternative titanium mesh technique or black bone technique. So black bone grafting is not necessary for 3-dimensional augmentation anymore. In my practice, I stopped using auto black bone technique for advanced ridge augmentation more than 10 years ago. If you want to get pure the vertical augmentation, I like to recommend use the sandwich technique with the interpositional bone graft. So once upon a time, I was a big fan of this technique, but I don't use this technique anymore because I could not implant the implants at the same time. So this technique has no effect on horizontal augmentation, but this is the vertical black bone graft, not pre-bone graft. So marginal bone loss is very, very minimal over time. This is a very challenging case showing more than 10 millimeter vertical defect in raw anterior area. This technique, this case report was reported in the Implant Dentistry, which is the official journal of ICOY in 2007. So sandwich augmentation, sandwich osteotomy using piezo surgery was done after after mobilization of this segmentation, this segment was moved to the coronally about 10 millimeter high, and the microplate was used to stabilize this segmented block. Pedicle graft and interpositional bone graft was done. After 6 months healing, 3 mini implant was placed to deliver immediate restorations. As I mentioned earlier, this technique has no effect on horizontal augmentation, so secondary horizontal augmentation using bovine bone and fibrin adhesive was used for secondary horizontal augmentation. This is before. This is 1 year. So vestibuloplasty was done at this stage. This is 2 years. This is 5 months loading. This is 12 years loading. You can see 0 bone loss with this technique. This technique has some advantages. So this technique was introduced by Jensen and Dr. Jensen in 2006. As I mentioned before, this technique shows you the very stable marginal bone loss thanks to the pedicle or bone graft. This is the segmented bone attached to the lingual periosteum. So this bone graft get a good blood supply from lingual plaque. Compared to the black bone technique, this technique is technically simple, so no donor site is required. But this technique has some also disadvantages. There is no effect of a horizontal bone augmentation, and you cannot place implant at the same time, so long edentulous period is required. If you want to know this technique more in details, please read these articles or this book, which I contributed 2 chapters. Chapter 12 talks about the sandwich augmentation, and chapter 16 talks about the minimally invasive sinus augmentation without grafting material, without bone graft materials. We should consider patient-oriented surgery for advanced ridge augmentation, not surgeon-centered surgery. So in order to do patient-oriented minimally invasive ridge augmentation, I like you to recommend to use a PR'BONE or StickyBone for solid space maintenance. This slide shows how to make your particulate bone graft sticky. There are 4 methods to make sticky bone. The oldest method is to use platelet-rich PRP, platelet-rich plasma, short-lived PRP. PRP was introduced by Professor Marx in 1980 to immobilize the bone graft and to accelerate the bone regeneration with the growth factors. The PRP is gained after 2 times centrifugation. This is slide shows first the result, test tube after first centrifugation. You need to take upper layer, including pink colored buffy coat, for second centrifugation. After second centrifugation, you can get the PRP, and this PRP is mixed with the grafting material, and you need to add the bovine thrombin and 10% calcium chloride to make sticky conditioned bone, which is called the PRP bone. I'd like to share some cases using PRP bone. After implant placement, you can see the huge horizontal defect here. So PRP bone was grafted without collagen barrier membrane. So because PRP bone is secured with the fibrin network, so the collagen barrier membrane is not required in most cases in horizontal augmentation. 6 months later, wound was reopened. You can see the good horizontal bone regeneration with the PRP bone alone. This is the final restoration. This is the almost 20 years loading. You can see the very stable marginal bone after 19 years loading. PRP has some disadvantages. This is technically sensitive, technically difficult. Double centrifugation is required, so the urosurgery can be delayed when you prepare the PRP. You need to add the bovine thrombin or calcium chloride, so it is possible. There is a possible cross-contamination from bovine thrombin. So you need to add some chemical additives. So only 10% of acquired blood is used. So this slide shows you second method to use the sticky conditioned bone for 3D ridge augmentation. This slide shows you that several different commercial gel putty conditioned bone. Okay, let me share some cases using this commercial putty bone for 3D ridge augmentation. This case shows you 8 mm vertical defect. What would you like to do to treat this case? Block bone, iliac bone, or titanium mesh? Or simple technique using sticky conditioned bone with the collagen barrier membrane. I placed the implant, this is the Dept. I placed the implant at the same time on the Dept as alternative to tenting pore to prevent collapse of the grafting materials, and pre-conditioned allograft overgrafting was done, and collagen barrier membrane was placed over the bone graft without membrane stabilization. Shoot or membrane tech primary shoot was done. The final restoration was delivered after 6 months healing. This is 12 years loading. You can see very, very minor marginal bone loss after 12 years loading. Is it necessary? Is it essential to use the titanium mesh or block bone technique for 3D ridge augmentation, or Lemus plate technique? I cannot agree with that. This is a newly developed commercial pre-conditioned bone, bovine bone. This bone contains the special bio-link, which is collagen. When you mix this bone with the saline or venous blood or autologous fibrin glue or PRF or whatever, you can get sticky conditioned bone immediately. So, even if it's shaken, it does not scatter. Commercial sticky bone has some advantages. It is easy to make. and easy to place on the bony defect, and there is no migration of bone graft during healing period, and your surgical time will be shortened, and this is cost effective compared to the any other expensive polyallergenic materials. Okay, here's a case using commercial putty bovine bone. You can see the vertical defect here. The full thickness flap was elevated, and you can see the horizontal defect here. What is your option to treat this technique? Titanium mesh or bony plate technique? But I like to choose this simple technique. I like to choose patient-centered technique. So the bone pen, which is a surgical guide, was used to place the implant at ideal site, and 2 implant was placed. The excellent initial stability was achieved, and to allow overgrafting of bone graft and to prevent the collapse of grafting materials, special tenting abutment was placed on the implant platform. This is the Santa 2, which has a 2 millimeter cuff high. This is Santa 1, which has a 1 millimeter cuff for horizontal augmentation. So the putty condition, the bovine bone was grafted on the defect. Take a closer look at the consistency of grafting materials. The bone graft was not washed off by saline irrigation as shown on this video. You can see the very good solid condition of grafting materials. And collagen barrier membrane was placed over the bone graft without special stabilization technique. Simple placement was done, and CGF membrane was placed over the collagen barrier membrane to accelerate soft tissue healing. This is before. This is post-op. This is technique. You can see that the bone of the Santa, or the head of Santa. The uncovering was done after 6 months. Because of COVID crisis, the uncovering was delayed. Wow, you can see the beautifully augmented, vertically augmented ridge here. The third method to make your particular bone graft sticky, you can use the commercial fibrin adhesive. The fibrin adhesive is indicated to control topical bleeding, soft tissue bleeding. But you can, when you mix with this fibrin adhesive with the bone graft, you can get sticky condition on the bone immediately. Okay, let me share some cases using sticky condition on the bone using fibrin adhesive. What are the options to augment this huge defect? What would you like to do in this area? This posterior mandible shows about 6 millimeter vertical defect. Would you like to use the complicated technique or simple technique? As a complicated, invasive technique, you can use block bone or ring bone, messy, or the bony plate technique as a staged procedure. I prefer to the patient-oriented, patient-comfortable techniques using simple GBR with a sticky condition bone as a one-stage procedure in order to reduce edentulous healing period. This is intraoral view. The full thickness flap was elevated, and lingual flap and buccal flap was released before implant placement to get good primary tension free shoots. And the mixture of bovine bone and allogenic material was mixed with fibrin adhesive to make it sticky. The pro-implant was placed at the same time as alternative to tenting pole screws. If you can place the tenting pole screws on the Dept, why don't you place the implant at the same time? So the bone graft was placed, membrane was placed on the under the lingual flap, and the fibrin glue was applied on the grafting material to stabilize the particulate bone graft. The simple placement of a collagen membrane was done, primary suture was done. After 7 months healing, wound was rebuilt. Temporary restoration was delivered. Please note, take a closer look at the no attached keratinized gingiva around implant restoration. So after making apically repositioned flap, the sutureless free gingival graft was done. This is final result. This is follow-up radiogram. This is baseline. This is 10 years follow-up. There is a little bit marginal bone resorption here, but generally speaking, the marginal bone looks like very stable with this simple technique. This slide shows you this advantage of commercial fibrin glue. This is allogenic materials. So some patient concerned cross-contamination and from bovine thrombin and allergic reactions. The main disadvantage of this glue is very expensive. So I prefer to use the autologous fibrin glue instead of using commercial fibrin glue, if possible. So this slide shows the last, my favorite method to make sticky condition the bone using autologous fibrin glue, shortly AFG. This technique was introduced Dr. Huang in Japan and me in 2010. After taking venous blood, patient antecubital fossa, this blood or venous blood is divided two different tubes. This is a yellow cupped 100% the plastic test tube. This is the lead capped glass or glass coated tube. After 12 minutes, plus the 2 minutes centrifugation, you can see the two different layers in the yellow capped tube. The upper layer is autologous fibrin glue. So in order to make sticky condition, you need to mix with the upper layer of the in the non-coated tube. After another 12 minutes centrifugation, you can see the three different layers in lead-capped tube. The middle layer is the fibrin block containing concentrated growth factors, shortly CGF. This slide shows you how to make sticky bone within 1 minute. After mixing grafting particulate graft material with AFG, I like to recommend you add coagulation factor attached to the CGF block to accelerate original sticky bone formation. Hold CGF block with a cotton flyer and cut RBC layer. Make sure to get a little portion of RBC layer. This RBC layer contains coagulation factors such as platelet. So after you need to compress this CGF membrane in order to make CGF membrane and mix with a mixture of particulate bone graft and AFG. Within 1 minute, whatever you use as bone graft, you can get original sticky bone simply, easily. As shown on this video. Yeah, you can see it's very solid, elastic condition of sticky bone. Dr. Jin Kim, Eric Ban, and Eric Park and I did the 4 days live patient surgical program together in 2015 and 2016 in Tijuana, Mexico. I introduced this how to make sticky bone to all attendees. So even though they tried to make a sticky bone at the first time, all attendees were successful to make sticky conditioned bone. Yeah. They was very happy with this result. This sticky bone can make your candidate augmentation. It's simple. This slide shows you some benefits of sticky bone. You don't need to use mesh or block bone for 3D-dimensional ridge augmentation in most cases. You can get faster bone regeneration thanks to the concentrated growth factors in sticky bone. You can place this graft material on all types of defects easily. And you can get a minimal loss of a bone graft during healing period. This slide shows the same image of sticky bone presented by Professor Oliveira. This is a bone graft. You can see the bone graft surrounded with the fibrin network. This is the blood cells entrapped in the strongly interconnected fibrin network. Sticky bone works well with all kinds of grafting materials. Nowadays, there are many copies of the original sticky bone. They call IPRF bone or sticky bone, PRF bone or PRF block, or they call it PRF bone. So original sticky bone plays a role of solid space maintenance in the ridge augmentation. As instead of using block bone, cover screw, mini screw, or titanium mesh, I recommend to use sticky bone for ridge augmentation in order to patient-oriented practice. This is the case using sticky bone for 3D-dimensional ridge augmentation. This is preoperative cone beam CT. Wow, take a closer look at the very low residual bone height on posterior maxilla, less than 1 millimeter. The full thickness flap was elevated. Now you can see that the bony communication through the sinus mucosa. You can see that the mucosal perforation here. So when the sinus mucosa is perforated like this, we cannot use the crestal approaches. So lateral approach to sinus augmentation was used with the piezoelectric bone surgery. You can see the artery inside the bony wall. Replaceable osteoinductive bony window was prepared with the physiosurgery. Make sure to do the bevel osteotomy at anterior osteotomy line and inferior osteotomy line in order to prevent the displacement of bony window after sinus elevation. It is very risky to use a burr in this case because the severe arterial bleeding is possible. So I strongly recommend to use piezosurgery to protect the artery inside the bony window. Thanks to piezosurgery's selective cut effect, the damage to the artery is very, very minimal during osteotomy. It's not a good idea to remove lateral wall with a surgical burr. This bony window is osteoinductive barrier windows, so don't waste this bony window with the surgical burr. You need to save this window with physiosurgery. Take a closer look at the large artery. And sinus mucosa is elevated. The implant was placed at the same time after doing on the osteotomy to get good stability of implant. The implant was placed. Implant acts as a tenting pole screw. In this case, the bone graft-free sinus augmentation was done, and lateral bony window, which is osteoinductive window, was repositioned, and one piece of the sticky bone, bovine bone, I think it looks like a mixture of the allogenic and bovine bone, was placed from palate and to the buccal over the crestal area. Collagen membrane was placed simply, primary suture was done. This is the post-op. This is 6 months healing. You can see the 100% vital new bone formation, living bone inside the sinus cavity. You can get good the vertical augmentation here, even though some bone migration, bone resorption is seen. This is the final restorations. The simple 3D augmentation using sticky bone is always predictable in narrow alveolar ridge. No, I don't think so. In some cases, when the alveolar ridge is very narrow, even though I use the sticky bone, the bone can be migrated apically because of the soft tissue pressure to the implant platform, as shown in this case. So implant was placed at the same time as an alternative to the tenting pole screw. And take a closer look at the very narrow alveolar ridge. Sticky demineralized osteoinductive mid-tooth bone graft was done, and the collagen membrane and CGF membrane was placed on the bone graft. This pre-op This is 3 months later. You can see some bone, marginal bone resorptions here. So when the bone resorption, when alveolar ridge is very thin, maybe we need more secure space maintainer, such as a low profile healing abutment or Santa. This is a temporal restoration. Stability of overgrafted bone graft over implant platform is essential for predictable 3D ridge augmentation. Therefore, a low-profile tenting abutment plays a role to maintain the volume of grafting material during healing period. Okay, this is a case using tenting abutment. Take a closer look at the huge vertical defect here. And the bone was very narrow here. So the ridge split technique using piezo surgery and ridge expander was done. After implant placement, the buccal plate was fractured. What would you like to do to control this problem at this stage? Would you like to place the micro screw? Impossible when you place the implant at the same time. The simple way to stabilize the fractured buccal segment is to place StickyBone over the fractured segment. To support the augmented augmented bone graft coronally, the 2 mm high the tenting abutment was placed at the same time. Sticky bovine bone was placed over the defect, and the 2 or 3 layers CGF membrane was placed over the bone graft instead of using collagen membrane. This is before. This is post-op. This is 4 years in function. You can see the excellent vertical augmentation with very minimal loss of bone graft. Thanks to tenting pore abutment, the vertically augmented bone graft did not migrate apically during healing period. Here's another case using tenting abutment for 3D-dimensional augmentation. Take a closer look at the huge vertical defect here. The soft tissue was elevated to see the bony defect. Piezoelectric bactericidal curettage was done before bone grafting, and the HPS technique was done to elevate sinus mucosa with water pressure without bone grafting. Sinus floor was elevated simply with water pressure, and to accelerate bone deformation in the sinus cavity in the new compartment under the elevated sinus mucosa, only CGF membranes were placed, and 2 implants was placed at the same time. Now you can see the partial loss of the buccal wall and complete loss of the palatal wall. The sticky tooth bone, osteoinductive tooth bone graft was placed. After placing 2 mm high tenting abutment on 24, tooth number 24. And 2 mm space was placed on the tooth number 24, 25 to accommodate customized titanium meshing. For comparison, I used 2 different techniques in this case. So on CGF membrane was carved over the bone graft. No collagen barrier membrane was placed. Primary, tension-free primary suture was done. Take a closer look at the tenting abutment and spacer. Yeah. Titanium mesh was exposed after 3 months healing, so I did uncovering procedure to remove titanium mesh in order to prevent possible infection. This is before grafting. This is after 3 months, 2 weeks healing. You can see the good bone regenerations around the implant. This is the before. This is the baseline. This is 6 years loading. You can see the very stable marginal bone thanks to the tenting abutment to allow the over grafting. Here's another case. This is preoperative intraoral view. This patient, when this patient visited me, he asked me to give him immediate restoration after implant surgery. Is it possible? Yes, I think so. As I mentioned on previous case, after extraction, immediate denture was delivered. After soft tissue healing, implant surgery and augmentation surgery was done at the same time. You can see the huge vertical defect on the left posterior mandible. So for the as alternative to the tenting pole screw, two implant was placed. At the same time, you can see now the 6 mm vertical defect. For horizontal augmentation, the mineralized osteoinductive mid-tooth-bone block was grafted on the buccal around premolar implants. And one mini implant was placed to support immediate fixed restoration. And this implant also used abutment for immediate fixed restoration. And 3 mm high tenting abutment was placed to allow or to prevent the collapse of grafting materials vertically. So patient extracted teeth, all teeth were prepared to osteoinductive bone graft after decalcification and sterilization process in vacuum sonic machine at chair side. Sticky tooth bone, MTB, was grafted. One collagen membrane was placed without membrane stabilization suture or bone tech. I don't want to lose my surgical time with the complicated technique. And CZF membrane was placed around around the over bone graft. This is the intraoral view after suturing. Immediate fixed restoration was delivered. This is post-operative radiogram. You can see that the vertical defect here. In this area, I did not place the tenting abutment for comparison. This is that because this area shows small vertical defect. And horizontal augmentation using tooth bone was done here. 6 months later, you can see the beautiful vertical 3-dimensional ridge augmentation thanks to the tenting pole abutment. This is before grafting. This is the 6 months healing. The healing abutment was removed. You can see the good bone regeneration around over the implant platform. This is the right side, posterior mandible. So you can see the vertical defect here. Sticky tooth bone alone was used, and I did the horizontal augmentation here with the same gram materials. Wow, you can see there is no migration of sticky bone after 6 months healing on premolar area. And this site was biopsied. Wow, look at the beautiful newly formed bone around the mineralized tooth bone. After 6 months healing, you can see the compact bone, mature bone between tooth bone, and you can see the newly developed Harvard systems. Excellent newly formed bone is seen around the dental, tooth bone. This is 2 years follow. You can see the very stable marginal bone on the both sides. Would you like to cast away patient extracted teeth to garbage, or would you like to make a novel osteoinductive bone graft after extraction? Unextracted tooth is no longer biological waste, so you can make particulate osteoinductive graft material, or you can make osteoinductive block bone or ring bone at chest side. According to the several publications, tooth bone should be decalcified before using it to accelerate bone regeneration with released diverse growth factor. If you do not decalcify enough tooth bone, the growth factor inside the dentinal tuber cannot be released. This is the chairside machine to make particularly tooth bone, block bone, or ring bones. You can make particularly tooth bone within 20 minutes, but you need 1 hour or 2 hours to make tooth bone, tooth block bone. This is a vacuum sonic device. This is my old augmentation using auto block bone. I don't use this technique anymore. So if I wanna use the block bone, I prefer to use a tooth block to hold grafting materials. This is my old technique. This is my new present technique using tooth block. This is my teams. They published the study on comparative morphometric evaluation of bone regeneration with different preparation of genogenic tooth bone block. 4 different types of tooth block was used to evaluate new bone formation. The demineralized human tooth bone with a hole shows the fastest new bone formation between bone block and the host bone. Now you can see the excellent newly formed bone over the tooth block. Well, this is a very amazing result, much better than autologous block bone healing. 8 weeks later, the calcified tooth block shows the bone remodeling process around at the junction of the host bone and the tooth block. Here's another case using simple. This is the comparison of the simple technique or complicated technique using titanium mesh. This both cases show you very similar situation. So on the left side, these 2 teeth was extracted and prepared to osteoinductive bone graft at chest side, and immediate implant placement and the ridge augmentation was done. On the right side, I did the delayed ridge augmentation with the simultaneous implant placement. You can, after implant placement on both sides, you can see that the 7 millimeter vertical defect here, and you can see the 3 millimeter vertical defect proximally. On the right side, you can see that the 5 millimeter vertical defect. The 2 millimeter high tenting abutment was placed on the left side. On the right side, the 2 millimeter space was placed to accommodate titanium mesh. The simple GBR using sticky tooth bone was done on the left side. On the right side, the titanium mesh was placed and the 3-point fixation was done. This is a very complicated technique, time-consuming technique. This is before, this is a post-op X-ray. You can see the good graft. You can see the graft materials over the tenting and pore abutment. After 4 months healing, wound was exposed on the left side. You can see the good bone regenerations around implant. On the right side, 5 months healing was revealed. You can see the good bone regeneration, but this is not bone. This is the 1 or 2 millimeter thick soft tissue. You can see the bone regeneration under this soft tissue. This is the before. This is 3-year function. This is a before. This is a 6-year function. Both cases shows you the same result, very predictable result. So you don't need to use a complicated technique using titanium mesh. It's enough to use a simple StickyBone technique when you do the 3-dimensional ridge augmentation, as shown on this comparison. Let's skip this slide. This slide shows you the specially designed tenting abutment to hold more bone over the implant platform. This is just Santa 1. Santa 1 has a 1 millimeter cuff, and Santa 2 has a 2 millimeter high cuff. This is a 1-stage Santa. This is you can use this one for immediate implant placement in extraction socket. Santa has some advantages, as shown on this slide. The Santa prevents collapse of bone graft during healing period and maintains the volume of grafting materials. And Santa technique is a simpler and less invasive augmentation procedure compared to the other complicated augmentation techniques such as mesh or block bone or bony plate technique. So, and you need to place the implant at the same time to use the Santa, so you can reduce number of surgery as a 1-stage procedure. So you can shorten edentulous healing time. Okay, let me show you how to use Santa 1 for horizontal augmentation. Implant is placed 1 millimeter deeper to the alveolar crest, and Santa 1 is placed, and bone graft was done, and the collagen barrier membrane or CGF membrane was placed over the bone graft, and primary suture was done. The Santa, the grafting material does not migrate because the Santa resists the soft tissue pressure to the implant platform, and the bone around the neck of the implant platform also well maintained. Here's case. This was extracted immediate, and this was extracted. Immediate implant placement was done. The bone pen was used to place the implant at ideal site. 3 implant was placed. So you can see the 3D implant, 3 millimeter high vertical defect here, and you can see horizontal deficiency around implant. This is the occlusal view. Santa 2 was placed for vertical ridge augmentation on the tooth number 47 side, and Santa 1 was placed on the tooth number 46 implant for horizontal defect. The sticky bovine bone was placed around the Santa, and the collagen barrier membrane was placed simply. And on the tooth number 4, after bone grafting, Sohn's pancho technique was done. The primary suture was done. After 3 months healing, 3 months, 2 weeks healing, wound was exposed again to evaluate the bone formation. Wow, look at the very beautiful ridge augmentation. There is no migration during healing period thanks to Santa. The final restoration was delivered. This is pre-op. This is X-ray after uncovering. This is a 6 months loading. You can see the very stable marginal bone after vertical augmentation with the Santa. Let me talk about a little bit on sponge technique. This technique was introduced in 2008. This is a surgical method to stabilize the CGF or pr membrane using healing abutment or prosthetic abutment at the implant site. This technique was described by me in 2008, and now it got popularized by the world, simply Pancho technique. So CGF membrane is pierced with a cotton fly or pincet or a blade to pierce the healing abutment to stabilize this membrane. You can use the healing abutment to stabilize healing CGF membrane or restorative abutment to stabilize the CGF membrane and stabilize the grafting material under the CGF membrane. This technique has many benefits. The CGF membrane accelerate wound healing at extraction socket, and this CGF membrane stabilize the grafting materials during healing period. In many cases, you don't need to do the suture at this stage, so you can minimize the suturing time. So this technique makes flap manipulation simple and easy. So post-operative complications are very minor. You can maintain zone of attached keratinoid gingiva with this technique. This slide shows you indications of Pancho technique. You can use this technique for single or multiple immediate implant placement as a one-stage procedure with the grafting bone graft. Or you can use this technique GBR without bone graft at sound extraction socket. You can use this technique GBR with bone graft at extraction socket showing bone resorption. This technique indicated for management of fatty implantitis. Okay, here's case using Pancho technique. This patient came to me from New York City, USA. Before she visited me, she came to several dental clinics in New York City, and she asked immediate restoration after extraction. All dentists refused to deliver the immediate restoration. So she came to me whether immediate restoration is possible or not from New York. So I promised her to give her immediate restoration after implant placement with the simultaneous ridge augmentation. These all teeth were hopeless. Extraction was done. On the same day, all extracted mandibular teeth was prepared to the sticky osteoinductive MTB. 3 implants was placed on each both posterior mandible, and the bone graft was done with the StickyBone, and Pancho technique was performed to accelerate wound healing, soft tissue healing. This is left side, the bactericidal curettage using piezo surgery was done, and 3 implant was placed, and sticky tooth bone was placed, and the Pancho technique was done to accelerate wound healing. Primary wound close was done, but you can see some exposed CGF membrane here, but the wound healing was not eventful. The excellent soft tissue healing was achieved thanks to the CGF membrane. Immediate restoration was delivered on the next day. This is a post-op radiogram. You can see the grafting materials around implant, vertically augmented ridge here. The final restoration was delivered after 5 months healing. This is post-op. This is 2 years on the two-year loading on the right side. This is the post-op. This is a two-year loading on the left side. You can see the well-augmented alveolar ridge. This slide shows you Santa 2. Santa 2 is suitable for vertical augmentation. Santa 2 has a 2 millimeter cuff height. So when you do the severe vertical, when you treat severe vertical defect, you need to place the implant as a tenting pole screw. 2 millimeter implant should be placed 2 millimeter deeper, 1 or 2 millimeter deeper to the proximal adjacent marginal bone, and place Santa 2, and overgrafting should be done, and collagen membrane was carved over the bone graft. Here's a case using Santa 2. You can see the mucosal thickening because of the hopeless teeth showing severe periodontitis. So these all teeth were extracted and prepared to the osteoinductive bone graft at chair side. This is the 2 weeks healing, 2 months healing. The mucosal thickening was reduced. What are the options to augment this huge vertical defect and sinus augmentation? Would you like to do complicated procedure using bony plate technique or Blackman technique or mesh technique? Would you like to do simple technique using StickyBone? This is pre-op cone beam CT. Full thickness flap was elevated. As soon as the buccal flap was elevated, the huge defect or the 10 millimeter bony communication was rebuilt, and second, small bony communication was rebuilt. Take a closer look at the huge sinus mucosal perforation. So it's very risky to place the grafting material, bone graft material, in the sinus cavity under the perforated sinus mucosa, even though collagen barrier membrane was used for mucosal perforation, for the repair of mucosal perforation. According to some study, about 17% of mucosal sinus infection was recorded under the perforated sinus mucosa. So osteoinductive, the ROB window, bony window, was prepared with piezo surgery, and the sinus mucosa was elevated with the sinus elevated from lateral window and bony communication. Osteotomy was done with a surgical guide, and the two Biotem implant was placed. Periosteal releasing incision was done before bone grafting. Make sure to get at least 10 millimeter overlapping of a buccal flap over the palatal flap to get tension-free primary shoots. After under osteotomy at implant site, implant should be placed to get stability of implant. To repair the preparation of large preparation of mucosa, past resorbable gelatin sponge was placed. This gelatin sponge holds the blood coagulum under the elevated sinus mucosa, so accelerate bone regeneration during healing period. And the CGF membrane, a few pieces of CGF block was also placed to accelerate bone regeneration in the sinus cavity. No bone graft was used because it's risky. I should prevent possible post-operative sinusitis in this case, 100%. So 2 Biotem implant was placed, and Santa 1 was placed on second molar implant, and Santa 2 was placed on first molar. Initial stability of implant was not strong, as shown on this video. Now you can see 6 mm vertical defect here and horizontal defect. Sticky tooth ROV window was repositioned to prevent soft tissue ingrowth into the sinus cavity. Collagen membrane was placed under the palatal flap. Membrane was squeezed in, and sticky tooth bone was placed, and the bovine bone was placed over the sticky tooth bone as a layered grafting procedure. This is the post-op before pre-op convexity. This is a post-op convexity. This is a 4 months healing. Now you can see the excellent 3-dimensional ridge augmentation and the 100% vital U-bone formation in the sinus cavity without any risk of post-operative sinusitis. This is a serial periapical radiogram before extraction, after extraction. This is a post-op. After 5 months, 2 weeks healing, the wound was exposed. Uncovering was done. Now you can see the excellent vertical bone degenerations. This is a final restoration. This is a 1 year, 6 months loading. The marginal bone is very stable. This is a very challenging case, a very difficult case to treat, but my surgery is very simple. If you use the sticky conditioned bone and Santa or tenting abutment for 3-dimensional ridge augmentation, your surgery also will be simple. The same patient, anterior mandible, I did the ridge augmentation with the simultaneous implant augmentation before sinus augmentation. Look at the huge defect here. 3 Biotem implant was placed. Initial stability was good, but take a close look at the more than 10 mm vertical defect. The lingual releasing incision releasing was done before implant placement. So one mini implant was placed to deliver immediate restoration for this young patient. And sticky tooth bone was placed over the implant, but I forgot to place a Santa in this case. This is immediate fixed restoration. After 5 months healing, the wound was exposed. The vertical augmentation looks good, but there is some bone disruption around implant neck. I should have placed the Santa in this case to prevent collapse of bone graft, to allow overgrafting. So secondary bone grafting was done and Pancho technique was done. This is before. This is final restoration. Not perfect, but it looks okay. This is 1 year loading. There is slight bone loss here. So I strongly recommend to use tenting abutment for vertical augmentation in order to get stable marginal bone. Here's another case using tenting abutment. This is a very severe severe cases showing vertical defect. My colleague's case, my colleague reported this patient to me, so I removed this failed implant and I did piezoelectric bactericidal curettage at the same time, and 2 implants was placed at the same time with the good stability thanks to endostomy. As I mentioned before, when you do the vertical augmentation with the tenting implant, tenting abutment, the tenting implant should be placed 2 mm, 1 or 2 mm deeper to the proximal bone height. And Tanta 2 was placed to accommodate, to allow the overgrafting. and to prevent the collapse of bone graft material during healing periods. The sticky tooth bone, the mixture of sticky tooth bone and bovine bone was grafted, and the collagen membrane was placed without stabilization technique, and primary wound close was done. This is pre-op, this is post-op, this is post-op. This is the convincingly after 4 months healing. You can see the excellent three-dimensional ridge augmentations with this simple technique. So this is the final restoration after 3 months loading. Maybe the pre-gingival graft is required here. This is before. This is 3 months loading. Very challenging case, but my surgery is simple. This is another case using Santa and StickyBone. After implant placement, you can see the 6 millimeter, the vertical defect, three-dimensional defect. So Santa 2 was placed, and the sticky bovine, one piece of sticky bovine was placed around exposed implant, and collagen membrane was carved. After 3 months healing, wound was exposed. You can see the good bone degeneration around implant. The temporary restorations. This is the final restoration after 6 months loading. You can see the this is radiogram after implant placement. Now you can see the excellent vertical ridge augmentation with this simple technique. Here's another case. These implants were failed, so extracted, and I placed the 2 new implant immediately after the cleaning this site. Santa 2 was placed on implant platform, sticky bovine bone was placed, and CGF membrane was placed to accelerate wound healing. This is post-op. This is okay. After 4 months healing, wound was exposed. This is before. This is after 6 months loading. You can see the beautiful vertical ridge augmentation with this simple technique. This is a similar cases. After remove of implant, 10 weeks soft tissue healing was allowed. There is no bone to accommodate implant over the implant inferior alveolar canal, so I decided to place implant a little bit lingual to the inferior alveolar canal at tooth number 37. So, as I mentioned before, many times do not consider complicated invasive technique for 3D ridge augmentation. So 2 implant was placed. In this case, the under osteotomy using Densabur in reverse mode was used to save bone during osteotomy to save inferior alveolar nerve. The 2 implant was placed at simultaneously, and initial stability was very good, even though this implant has only 2 millimeter apical engagement. Now there is the 6 millimeter vertical defect. Santa 2 was placed on each implant. You can see the complete loss of the lingual and buccal bone. This is occlusal view. Sticky bovine bone, mixture of sticky porcine and mineral allograft was grafted. Collagen membrane was placed. CGF membrane was placed over the collagen membrane to accelerate wound healing. Primary suture was done. This is before. This is post-op. This is pre-op convincingly. This is post-op convincingly. Now you can see the implant positioned lingually to the alveolar canal. 5 months healing was allowed. There is good bone regeneration around implant. This is final restorations. Okay. So as I mentioned before, there are many advantages of Santa procedure. This technique simplify your ridge augmentation. No, you don't need to place a bone tag or membrane stabilization shoes. This technique prevents vertical and horizontal collapse of a bone graft during healing period. And this technique maintains the volume of a bone graft of the implant platform during healing period. So you don't need to perform complicated surgery using black bone bony plate or titanium mesh or Gore-Tex with the membrane tags. It's time to think outside the box with ridge augmentation. No more invasive old-fashioned ridge augmentation as shown on this slide. No more black bone in my practice. No more bony plate in my practice. No more tenting pole screw in my practice. No more titanium mesh in my practice when I place the implant simultaneously. No more stabilization technique for membrane. This is not easy job. This is my conclusion. Let's follow. Keep it smart, simple principle with the sinus ridge augmentation. Simplicity is the best option for our patient. Isaac Newton said, nature is pleased with the simplicity and nature is no dummy. Thank you very much for your kind attention. Thank you so much.